Episode 35, Growing Pain in a Professional Golfer. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide some practice questions. Okay, here's the case. 25-year-old professional golfer who had been playing on the PGA Tour for approximately 6 years. There's no prior history of any groin or abdominal injury, although he did have some occasional complaints of right hip pain described as anterior location and pinching in quality. He reported the current injury when he was doing an independent exercise session. He had been doing a high volume of abdominal exercises and pull-ups. He felt soreness during the workout, but wasn't until the next morning when he tried sitting up in bed that he realized something was wrong. He had pain in his right groin when he tried to transfer from sitting to standing after rising from his bed. He also noticed coincidental pain when he loaded his core. This included pain with planks, pull-ups, push-ups. He also had symptoms when he was swinging a driver, but did not describe pain with smaller club sizes, including irons or wedges. He denied pain with sneezing, coughing, toileting, sitting or walking, or at rest. The initial physical examination described localized tenderness to palpation in the right lower abdomen, particularly proximal to the inguinal ligament. There was no palpable deformity or hernia identified, and several provocative tests were positive. The Stinchfield test, which is a resisted active straight leg raise at 45 degrees, reproduced his symptoms. Pain was also reproduced with resisted right hip adduction at 0 degrees of hip flexion. Hip examination showed passive hip internal rotation at 35 degrees on the right and 40 degrees on the left. Fader testing was negative, and a modified Thomas test was negative bilaterally. Faber testing showed decreased range of motion on the right compared to the left, but was not painful. The patient was seen initially by a physical therapist and then by a physician the following day, who described similar findings, and there was no initial imaging performed. The differential diagnosis I came up with was potential intra-articular hip pathology, including labral tears, abdominal oblique strain, and inguinal or sports hernia. I'd like to recognize the authors. This report was published in 2014 in the International Journal of Sports Physical Therapy by Lindsay Becker and Dave Kohlrieser from Ohio State University. I am Scott Hall, a primary care sports medicine physician, and I am studying for my sports medicine recertification exam in 2026, and I hope you'll join me on the journey. This podcast is for educational purposes only. Okay, the authors made a provisional diagnosis of a sports hernia and proceeded with conservative management with physical therapy. I want to talk a little bit about how this diagnosis was supported. The authors referenced a cluster of 5 symptoms described in the physical therapy literature that are most indicative of a sports hernia. These 5 findings were: first, a subjective complaint of deep groin or lower abdominal pain; second, pain worsened with sport-specific activities and relieved with rest; third, palpable tenderness of the pubic ramus at the rectus abdominis or conjoined tendon insertion; fourth, pain with resisted hip adduction; and fifth, pain with resisted abdominal crunch or curl up. This particular patient just demonstrated all 5 of these symptoms at the time of initial presentation, which they described as strongly supporting the working diagnosis. The authors also noted that an MRI may be useful to rule out other pathologies, but can be normal in patients with a sports hernia diagnosis. The initial plan was to proceed with conservative physical therapy for the first 2 weeks, with consideration of more aggressive intervention if no improvements were made. The treatment was structured around a stepwise progression through what the therapist described as neurodevelopmental sequence of postures. This means starting with non-weight-bearing positions and progressively loading the body in different postures. Exercise intensity progressed from isolated activation of the transverse abdominis and gluteal musculature to perturbation retraining to resisted motion against external loads and ultimately to sports-specific activities. After 1 week of physical therapy, the patient reported pain had reduced to 2 out of 10 with sitting up from bed. He had been able to continue hitting with wedges and irons up to his 7 iron daily without pain. By week 3, the patient could perform a supine crunch without pain, though he still had 2 out of 10 pain with oblique crunches. He was hitting unlimited balls with all irons at this point, but had not yet used his driver. The patient was seen overall for 13 physical therapy visits over 4 weeks. At the conclusion of formal physical therapy, he reported 0 out of 10 pain with all golfing activities and sitting up from bed. He still had mild pain with planks, pull-ups, and push-ups, and those were initially excluded from his strength and conditioning routine for an additional 6 weeks. 7 weeks after the initial injury, this professional golfer returned to competitive play without pain or limitation. A couple of points that I want to include: the authors are transparent about the limitations of this case report. There was no definitive pathoanatomic diagnosis, and sports hernia remains a diagnosis of exclusion and primarily a clinical diagnosis. The patient's pre-injury fitness level and motivation as a PGA Tour professional may not be representative of recreational athletes. A couple of key takeaways from me: sports hernia, also is termed athletic pubalgia, is a clinical syndrome of chronic groin or lower abdominal pain caused by weakening or tearing of the abdominal wall musculature without a true clinically detectable hernia. The preferred broader term in recent literature is groin pain syndrome, as the inclusion of a hernia is considered a misnomer. Please look at reference 2 for that statement. The pubis serves as a pivot point between the abdominal musculature, including the rectus abdominis superiorly and the adductor muscles inferiorly. The imbalance of forces across this function at the pubis leads to common pathologic findings. Number 1, weakness or bowing of the posterior inguinal wall or the transversalis fascia without a direct hernia. Number 2, tears or strains of the rectus abdominis insertion and or adductor longus tendons. Number 3, disruption of the internal oblique or conjoint tendon. Number 4, splaying of the external oblique aponeurosis. Number 5, inguinal neuralgia from nerve compression or bowstringing. Number 6, pubic symphysis pathology, including bone marrow edema, often described as a double cleft sign on an MRI. According to recent literature, a sports hernia is most common in athletes performing cutting, pivoting, kicking, and sprinting. This can include sports like soccer, ice hockey, and football. The overall incidence of groin pain among athletes is estimated at somewhere between 2 to 20%. Key features of a sports hernia include insidious or acute onset of unilateral groin or lower abdominal pain, often radiating to the perineum and proximal hip adductors. Pain exacerbated by athletic activity and reproduced with resisted sit-ups, forced cough, or sneeze. Tenderness over the pubic symphysis and surrounding structures. The diagnosis of a sports hernia is primarily clinical, requiring a high index of suspicion. Important considerations for the physical exam include tenderness to palpation of the pubic symphysis, rectus insertion, and/or adductor origin. No palpable inguinal hernia should be identified. It is also important on physical exam to assess for concurrent femoral acetabular impingement. An MRI can be useful for ruling out other pathology and identifying rectus or adductor tears, bone marrow edema at the pubis, and, as I mentioned previously, a double cleft sign, though it may underestimate the extent of the injury. Dynamic musculoskeletal ultrasound can be used as a diagnostic modality according to recent literature. That's not something I've been able to perform in my practice. One source referenced a lidocaine injection as a potential diagnostic option to localize the pain source, and management of a sports-related hernia, best described in reference 1, outlines a structured approach with first-line conservative management, including rest, anti-inflammatory medications, and a structured physical therapy rehabilitation program for at least 12 weeks, similar to this particular case report. Surgical treatment is reserved for failure of non-operative treatment. Surgical treatment may include open or laparoscopic mesh repair of the posterior inguinal wall, primary tissue repair with relaxing myotomy of the conjoint tendon, a rectus abdominis reattachment, and adductor tenotomy when concurrent adductor pathology is present. Return to play. After an isolated surgical repair, it's typically relatively quickly at approximately 4 to 8 weeks. If combined with an adductor release, the literature describes typical return to play at 12 weeks. In one series of 93 patients undergoing laparoscopic repair with adductor tenotomy reported 92% return to athletic activities within 28 days. The overall evidence in the field regarding sports hernias and treatments remains relatively low quality, consisting largely of case series and expert opinion. There is substantial variation in terminology, diagnostic criteria, and surgical techniques across geographic regions and surgeon subspecialties. So keep that in mind. All right, practice questions. Which of the following best describes the pathoanatomy of a sports hernia or athletic pubalgia? A. True inguinal hernia with a palpable fascial defect caused by repetitive athletic activity. B. Weakness or tearing of the posterior inguinal wall and or musculotendinous structures around the pubic symphysis without a clinically detectable hernia. C. An incarcerated femoral hernia presenting with groin pain during exertion. D. Avulsion of the sartorius muscle from the anterior superior iliac spine. The correct answer is B. A sports hernia or athletic pubalgia involves disruption of the abdominal wall musculature, transversalis fascia, and or adductor attachments at the pubic symphysis. Despite the name, no true hernia is present on clinical examination. Question 2. Which of the following statements regarding MRI and the evaluation of suspected athletic pubalgia is most accurate? A. MRI is the gold standard and definitively confirms the diagnosis in all cases. B. MRI may reveal rectus abdominis or adductor tears, bone marrow edema, and the double cleft sign, but may underestimate the true extent of injury. C. MRI is not indicated and has no role in the workup of groin pain in athletes. D. MRI findings always correlate with symptom severity. The correct answer here is B. MRI is useful for identifying associated pathology such as rectus or adductor tears and pubic bone marrow edema. However, the diagnosis of a sports hernia remains primarily clinical. Question 3. A 28-year-old hockey player undergoes surgical repair for athletic pubalgia but continues to have groin pain postoperatively. Which of the following coexisting conditions is most important to evaluate in this scenario? A. Lumbar disc herniation. B. Femoral acetabular impingement. C. Piriformis syndrome. D. Iliotibial band syndrome. The correct answer is B. Femoral acetabular impingement frequently coexists with sports hernia or athletic pubalgia and, if unrecognized, is described as a common cause of persistent symptoms after surgical repair. Evaluation for concurrent hip pathology is a critical component of the workup of a sports hernia. Question 4. Which of the following is the recommended initial management strategy for a patient diagnosed with athletic pubalgia? A. Rest, anti-inflammatories, and a structured physical rehabilitation program for at least 12 weeks. B. Immediate surgical repair to prevent progression. C. Corticosteroid injection into the inguinal canal. D. Immobilization of the hip. The correct answer is A. Conservative management is the first-line treatment and should include activity modification, anti-inflammatory medications as needed, and a structured rehabilitation program lasting at least 12 weeks, according to recent literature. Surgery is reserved for patients who fail non-operative management. Question 5. A 26-year-old professional football player undergoes laparoscopic posterior inguinal wall repair combined with adductor tenotomy for refractory sports hernia symptoms or athletic pubalgia. What is the expected timeline for full return to athletics? A. 1 week. B. 4 weeks. C. 12 weeks. D. 6 months. The correct answer is C. After an isolated posterior wall repair, return to play is typically around 4 weeks. However, when adductor tenotomy is performed concurrently, the expected recovery period extends to approximately 12 weeks due to additional soft tissue healing required. Thank you.